Constructing a clinical question. Creating a clinically relevant question is frequently more complex than it originally appears. We need to make sure that we identify the key patient problem. There are different types of clinical questions. For example, maybe an intervention question. What effect does a treatment have? We could ask frequency or occurrence questions. How often does a problem occur? Etiology or risk factor questions. What causes a problem? Diagnostic or testing questions. Does this patient have a specific problem? We could ask prediction problems. Who will get the problem? Or phenomena questions. What types of problems may be occurring in a given population? The question then needs to be phrased to facilitate finding an answer to the question. We need to consider what treatment might be considered, alternative treatments to consider, and outcomes to avoid or to promote. A searchable clinical question has 3 or 4 or even sometimes 5 components: the patient or problem, or both, the intervention, prognostic factor, treatment, or exposure, often the comparison intervention, the treatment you are curious about, and the outcome measure by which the intervention is appraised. Some clinical questions also include a 5th factor. This is the time or the type of study. Some searches only have one intervention or comparison component. These are typically referred to as a PO, PICO, or PICOT aspect of a clinically relevant and searchable question. The patient, population, or the problem identifies the group to whom the results of the question will apply. While it is often implied, it's better to be specific. For example, instead of asking, "What is the most accurate test for the diagnosis of chest pain?" Adults are implied in this. It might be better to say, "In adults with chest pain, what is the most accurate test?" All of the following could be used to help you define the population for your question: age, race, ethnicity, and gender or sex. Sex is biological. Gender is a social construct. The clinical setting. Is it an emergency department or maybe a primary care office or even in a clinical setting? Are there comorbidities such as patients with known heart disease or patients with diabetes? Are there specific geographical locations that you're looking at? For example, rural versus urban areas. When choosing the population for your question, try to be reasonably specific without making your topic so narrow that no one will be able to use it. An example of this might be looking for postmenopausal women. If we make this so specific, we might include postmenopausal African American women in the primary care setting in rural Georgia. By asking our question and defining our patient population so specific, we have effectively eliminated large other populations that might be good to compare to. So we want to be as specific as possible without getting too specific. This is a tough tightrope to walk. When we think of the term intervention, we usually picture a prescription for a drug. Remember, though, interventions can include surgery, complementary or alternative medicine such as yoga, exercise and physical therapy, counseling, a combination of treatments compared to a single treatment or to a different combination, or even patient or medical education. Also remember that diagnostic tests are a form of intervention. For example, these diagnostic tests could include a blood test, an imaging study like a CT or an MRI scan, other tests like endoscopy or cardiac stress tests, history and physical examination maneuvers, clinical decision rules. Essentially, anything that we do to or for our patients is considered an intervention and could be the topic for a clinical question. Sometimes we have multiple choices to treat a condition. Take acute bronchitis. We have amoxicillin, erythromycin, or no antibiotics that could be used to treat this. Remember that doing nothing, also known as premium non nocere, is also an option. After all, many new and promising interventions have turned out to be worse than doing nothing at all. Finally, each well-formed clinical question should also have an outcome. This is important because not including an outcome makes it much harder to answer the question. For example, when asking a question about hypertensive therapy, is your outcome reducing blood pressure, reducing cardiovascular mortality, or all causes of mortality? When deciding between two different diagnostic tests, you may want to consider if accuracy alone is enough to answer our question. Or are you more concerned about the accuracy of the test and the cost? Or even the impact on the patient's final outcome? I would encourage you to frame your question so that it asks about patient-oriented outcomes. That way, your answer has more potential to be a POEM, patient-oriented evidence that matters. Patient-oriented outcomes include morbidity, mortality, symptom improvement, cost, and even quality of life. These are the things that are most important to most patients. Sometimes, especially in medicine or athletics, time to return to activity or work is an important factor. For example, an open versus a closed surgery. Recovery time can be drastically different. Additionally, when we consider sports seasons, some are very long while others are extremely short and may only be a few months. Therefore, the time to return to activity can play an important part in defining our clinical question. Additionally, some people include the type of study in their clinical question. There are different types of study designs, which we'll cover in increased depth as we progress through this course. By defining the different types of studies, we can include or exclude different types of variables and may be able to either expand or narrow down our search to answer a clinical question. Many different types of clinical questions can be formulated, and the makeup of the question will depend on the information you are seeking. Information or therapy questions will assist a clinician who is trying to determine the efficacy of a treatment chosen to address the patient's needs, and may assist in determining the factors that are important for immediate results, as well as long-term outcomes based on the condition. Etiology questions refer to the examination of the cause or causes associated with greatest risk for a condition. They can also be used to determine the primary elements or factors that are associated with the greatest risk for a condition to occur. A diagnostic or diagnostic test frame question is appropriate when you would like to determine whether one test is better at assessing if an individual has a certain condition. Prognostic or prediction questions can be used to determine the factors that may complicate the clinical plan of treatment over a period of time. Additionally, these questions can be used to incorporate this information to better assist the patient with a favorable outcome. Meaning-phrased questions can assist with understanding the meaning of an experience for a particular individual, group, or community, and frequently deals with obtaining perceptual information from the patients. I would encourage you to consult with this table frequently during our course to help you as you are developing your clinical questions and assignments and activities. So let's put what we have learned into practice and see if we can apply what we have learned in a practical scenario. Let's take this case, pickles. Yes, that's right, the case of pickles. This information has been posted online and is readily accessible to everyone. So while I know this does not relate back to sport or exercise, this is still a good case to examine and see if it makes any sense. Apparently, there is an anti-pickle sentiment out there in the world. They have posted the following: pickles will kill you. Every pickle you eat brings you nearer to death. Amazingly, the everyday person has failed to grasp the terrifying significance of the term "in a pickle." Pickles are associated with all major diseases of the body. Eating them spreads wars and communism. They can be related to most airline tragedies. Auto accidents are caused by pickles. There exists a positive relationship between crime waves and the consumption of this fruit. So now that we have this information, let's run the numbers to see if we could develop a clinical question to see if this is actually true. There is additional data that has been provided to further the case against pickles. So let's take a look. Nearly all sick people have eaten pickles. Therefore, the cumulative effect of pickle consumptions are obvious. 99.7% of people involved in air and auto accidents ate pickles within the 2 weeks prior to the accident. 93.1% of all juvenile delinquents come from homes frequently serving pickles. As if this wasn't enough, there's more. 99.9% of all people who die from cancer have eaten a pickle at some point during their lifetime. 98.9% of all soldiers have eaten pickles. And 96.8% of all communism sympathizers have eaten pickles. As you can see from this slide, they have included a lot of different statistics, and many of them are very high percentages. Sometimes when individuals are trying to prove a point, they may include a lot of statistical figures. It is our job to determine if those statistical results have any meaning. So let's keep exploring. They also go as far as to list the long-term effects of pickle consumption. Of the people born in 1839 who later died on pickles, there has been a 100% mortality rate. All pickle eaters born between 1829 and 1939 have wrinkled skin, have lost most of their teeth, have brittle bones, and failing eyesight if the ills of pickle eating have not already caused their death. Even more convincing is the report of a noted team of medical specialists. Rats force-fed with 20 pounds of pickles per day for 30 days developed bulging abdomens. Their appetites for wholesome foods were completely destroyed. So, what do we do? I know, just outlaw all consumption of pickles. Well, based on this information, it sounds like we need to stop eating pickles. We want to protect those that we love. Remember, only you can fight death by pickles. For many people, this is as far as they go in their critical analysis of the situation. If numbers are reported, or if there is a research article put out on something, they just believe it without questioning the results of the information with which they are presented. Now that you're a young researcher and clinician, we have another choice. Let's see what we could do. Our other choice is to develop a clinically relevant and searchable question. We can use our knowledge of evidence-based practice to examine patient-oriented evidence that matters and disease-oriented evidence to examine the risks associated with the consumption of pickles. Remember, there are 3 basic components to evidence-based practice: clinical expertise, patient values, and the best available evidence. So let's take a look at each of these 3 components of evidence-based practice before we ask our question. Let's start with clinical experience. Clinical experience is the clinician's cumulative experience, education, and clinical skills. I've eaten pickles and I'm still alive. I also know others who have done the same and are in good health. I would also think that if this was an actual problem, pickles would not be available in the supermarket. So that's my clinician expertise. Next, let's look at patient values. The patient brings to the encounter his or her own personal and unique concerns, expectations, and values. For most people, they could say, pickles are delicious, unless you hate pickles. Pickles complement my sandwich, hamburger, salad, or even hot dog. Many pregnant women will be completely heartbroken if they cannot have their pickles and peanut butter. Ugh, that's a rough combination, but I'm sure they love it. Next, let's look at the best research evidence. We can do this typically by doing a research data search. Obviously, this report was for amusement and demonstration purposes only. Although many of the statements may be true, they're pretty useless. There are situations for which value and credibility of the report cannot be easily assessed. Another example of this would be from the presidential election for John F. Kennedy. He stated that 25 million people in the United States go to bed hungry. In commenting on his statement, Time magazine stated that in their opinion, 44 million people went to bed hungry every night because they were dieting, not because they didn't have access to food. This fictitious remark illustrates the fact that such statistics have no base of fact and cannot necessarily be substantiated. Our world is full of phony statistics. As we're examining the best research evidence, we would want to look at the statistics to see if this data can be substantiated. I've seen the data, but do I believe it? Where did the data come from? And are the statistics reasonable? Now let's go one step further. We want to develop a clinically relevant question to examine this issue of pickle consumption. Before I go through this exercise with you, I would like you to pause the video here. Just like this picture that has a wolf hiding in the trees. I want you to see if you can decipher how we would ask a clinically relevant question and then try to answer the PO, PICO, or PICOT parts of the pickle problem. Your answers may be different than mine, but that's okay. You can compare your thought process to my thought process as we go through and work through the problem. So please press pause and work on the problem yourself. And now we're back. I hope you have your problem in front of you. For those of you who have been trying to find the wolf, here it is circled in blue. And back to our pickle problem. One way would be to look at this from a prognostic or prediction standpoint to determine the risks of pickle consumption over time. Remember the table that we saw earlier? Well, it's back! Prognosis or prediction questions can be used to determine the factors that may complicate the clinical plan of treatment over a period of time. Additionally, these questions can be used to incorporate this information to better assist the patient with favorable outcomes. For a busy clinician, patient-oriented evidence that matters, or a POEM, is probably the most useful type of article to read. It is also what our patients are probably most interested in. These types of studies look at outcomes and quality of living. What is crucial is that we select studies that matter. There are more and more patient-oriented evidence in the literature. Choose to read those that matter both to us as a clinician and to our patient population. A DOE stands for disease-oriented evidence. These studies help us to understand the etiology, prevalence, and pathophysiology of disease. These studies are important because they give us insight into the disease process. However, they are less helpful in our clinical management of patients. One example of our critical question may be, in all people, how do pickle eaters compare to non-pickle eaters' risk of developing cancer over their lifetime? Let's remember our PO, PICO, or PICOT, as well as to continue to expand on the question. For this question, we're going to choose the PICOT format. Let's break it down. First, we're going to start with our patient population. We have defined our patient population as all people, or the general population. Our intervention of interest is anyone who's eaten pickles, or pickle eaters. We could actually make this more specific if we wanted to. It may be people who eat pickles on a weekly basis. Next, our comparison of the intervention or issue of interest. Our comparison would be those who do not like pickles or don't eat pickles. Our outcome of interest has been identified as the risk of cancer, and the time of interest is the lifetime of the patient. So, understanding how to write a clinical question is the first step in the evidence-based practice process. The ability to write an effective clinical question will assist you in finding the best possible evidence to support your practice. A good question will also allow you to engage with fellow clinicians and practitioners in shared decision-making processes. This also helps us to improve our overall patient care, which should be the ultimate goal of all healthcare providers.